Good morning, everybody. Let me start with thanking the 3D team and the rest of them for giving me this wonderful opportunity. At the outset, I have two requests. Sir, I have one due to prayer commitment. After this, I'd leave and not be there for the question and answer session. Thank you. Yeah. That said, I also have to say that there is going to be a lot of overlap in what we are talking about. So kindly do bear with us. The goal in a hospital setting, at least in the non-critically ill, is to bring them under control during the time you have. This is done mainly by recurrently measuring the blood sugar. So the number of blood sugars more you measure, better the idea of how they react to each drug and what is the problem that can be needed out. And prevention and treatment of hyperglycemia, when the patient goes out, you want a better control. This will depend upon 3-4 things. One is the type of blood sugar. Let us say they are type 1, then obviously insulin is the only choice. In type 2, there could be this thing. In a patient's prior treatment, they are on OHA, they are well controlled. Possibly in a non-critical setting, you will continue. Whereas in a critical setting, you would have to take it out. Then again, if patient is going ill per over, he's come for a loose stool for vomiting, then again you may need insulin. So it will depend upon the prior value and the way they were controlled and the type of diabetes and the type of calorie intake they are going through. The monitoring is generally done, one frequency is that in a normal patient, what you do is before each meal you take it, because that's a very fixed value, you take that. People who are on nil per oral, they are on the fixed interval of 6 hours, you can start doing it. Generally, nowadays, capillary blood glucose is the main thing of choice because of other reasons also. There are even studies which have proved that you can create anemia by recurrent number of blood sampling. So, capillary blood glucose is the method of choice. But then, in a non-critical patients, CGM has been used because you don't need to puncture them a number of times, and you can tell them what they are eating, what has happened. In a patient, many of these sick patients would be on a liquid diet, semi-solid diet. There it will go up. So it will be a good learning exercise in such this thing. Glycemic target already has been alluded to by the prior speaker. Generally non-critically ill, you try to keep the fasting below 140 and anytime value below 180. In critically ill, obviously, because of you don't want to create hypoglycemia at all in such patients, 140 to 180 at any time, never landing below 100. Treatment of patients with type 2 depends upon the previous therapy, as I said, like on their food habits, contraindications, which we have already alluded to. These are to be taken into account. If a patient's glucose is persistently high, more than 180, that is the time you need to intervene. Like for example, they are on OHA, they come for a simple thing, let's say local surgery. They are well controlled, possibly will continue with their old regimen and this thing. They are uncontrolled due to the stress of hospital admission or due to the way their eating pattern has changed or because they have not taken the OHA, then and correction dose of insulin can be started and they can go back to their original therapy. For a reasonable glycemic management, an HbA1c of less than 8 as the target during the stay, because again hypoglycemia is a big no-no. Of the OHs, DPP4s have the best thing because they do not cause hypoglycemia, they are easy to use and they potentiate the use of insulin, you get a better control. So if they are on DPP4 inhibitors, you can continue that. SGLT2, there are certain times when you may need to continue, but in critical ill patients, you will take it off. Mainly sulfonylureas are the drugs you like to take off during an hospital stay because obviously you don't want anybody to go in for a hypoglycemia. Any patients who has been taking insulin prior to hospital, you would continue the regime if they are well controlled. If they are unable to eat normally, then obviously GLP-1 analog, all those things, SGLT2s are taken away and you will continue you will start off on insulin therapy. The previous regimen, if they have been on an insulin you will give correction doses, get them under control, see if they need to Let us say they were well controlled a week back because of the fever that has gone up. Then when the fever comes down, they may go back. So you can possibly restart them on their old therapy. If not, you would like to add to the therapy and then send them home. So the idea is to bring it down during the hospital stay as a learning experience. Insulin basically, patients treated with insulin therapy should be continued on insulin. a type 1 or any type 2 who needs insulin initiation, please make sure that even if there are patients who come with 1-day history of vomiting and ketones body presence. So in such patients, that is the time you tell them that you need to go on insulin. Tell them the reason why such things are happening. You know, as sir already alluded to, they always say, last month it was 500, so it's come down to 200, I'm very happy. That's not the way we need. That's the time we educate them for other thing. Insulin pumps have also been used in hospital settings in the West, but one cost, other education, all those things may be a reason why here we don't do that. In a well-managed patients, during the hospital stay, if they are very well controlled, let's say an HbA1c of 6.5, in such patients, you generally tend to take only 50% of this thing because his eating pattern is going to change here. See how the wind blows, then go back to the therapy. We have already seen the last group discussion, what are all the newer insulins. The faster acting, IV insulin is always regular, but faster acting insulins are a way out if you want to give just correction doses in a moderately controlled patients. The long acting insulins have a basal insulins have a plus point. Rarely hypoglycemia is seen, and titration is more difficult because once in 3 days only you are going to titrate. But then when there is only a fasting is increased, possibly to bring down the fasting, in some places this can also be used. But generally the basal bolus is what is the correct thing. You start with the basal. If you are just starting insulin, you start with the basal, and you will be able to give correction doses and get the total amount of insulin that's necessary. When they go, 50% of the basal is taken and rest is by the meal you can just think. Your idea is not to bring back to physiological limits. Idea is to bring it down below 80 at that time. See how it works on, and when they go back home. They could be eating more, they could be eating less. Possibly in the hospital, they don't get the type of food they get in home. So the fiber content may be different. With all that, you don't tend to absolutely normalize and send. You tend to get them below 180, send them, make them come back after a week time, then titrate it. So the idea is to have a basal insulin at anybody who is not controlled. Then possibly you can titrate with a correction doses of bolus insulin and get them under control. Sliding scale, as we already alluded to, is a no-no. But one place where Americans do seem to use it is in a very well-controlled thing where you need to know the total amount of dosage that's necessary. Some people do use it because over the phone they can tell the other thing. For that convenience, some hospitals still have a sliding scale, which is not, we don't recommend it. But then that does occur. If you are using an IV insulin, the correction doses by a sliding scale is acceptable because total dosage calculation becomes easier. And as I already alluded to, in any of this thing, IV insulin, it's only the regular insulin which is used. The requirement of exogenous insulin during and prolonged fasting disappears in type 2. Even after prolonged fasting, in type 1, you need insulin. So, like in insulin, even basal is not there. So, even after prolonged fasting, NPO, so you don't want to totally this thing. There are basal amount of insulin needs to be given at least according to the meal. That needs to be the thing. You can check and keep giving insulin. But in type 2, sometimes when they go nil per oral or they are on very little foods, the amount or need for insulin does come down. General rule of thumb is that you start with 0.4 units per kg body weight. Total dose is brought out either with a sliding scale or IV. Then you take 50% as basal. Rest is into divided with each prandial thing. If possible, you check and then give each the thing. Generally, a glargine or one of the newer insulins are taken as a basal because the chance of hypoglycemia is much lesser. To build on is easier, but cost is a constraint in India where you need to look at. Insulin infusion is very useful even in non-critical setting because, like again in total dose calculation, this is very, very important. But then with the current subcutaneous insulin, which acts very fast, you can decide on the meal, look at the numbers, and then give other thing. So in such patients, the current ultra fast acting insulins can be utilized in some of the things. But anybody, the base the thing is that if patients have a very high blood sugar, better to use an infusion of insulin, get them under control, know the total amount, then when they are getting discharged, break it down into the basal bolus value and send them home. Key point is that the patient have at least a small amount of insulin circulating all the time. And insulin infusion, the biggest plus point is they are going for hypo, can stop In 3 minutes, the insulin action is over. So it is easier to adjust and know the total amount. That is the real plus point of an infusion of insulin. It is more cumbersome. It's more the number of times you need to check increases. The work the nursing station has to do increases. So a lot of people do have trouble in continuing insulin infusion. But then that is the reason why they do have insulin infusion. Intravenous regular infusion is started with an approximately half of the patient's total dosage. Then, according to their blood sugar values, you titrate it. It started at 1 to 5 units per hour and increased up, with the pre-meal level at each point. In patients who are not eating, concomitant glucose infusion is necessary so that calories are given. With that, you titrate the insulin. When patient receiving intravenous insulin is more stable, prior insulin, if they were well controlled, your baseline HbA1c is good, possibly you can go for that. And then correction doses alone can be given as an extra. If intermediate or long-acting insulin is used, it should be given 2 to 3 hours prior to discontinuation. Because as I told you, the insulin infusion, you stop within 3 minutes, its action is over. Whereas the subcutaneous takes a longer curve. So you start that, then stop the insulin infusion. Patients with type 1 diabetes, you have to continue insulin. Make sure that they are on insulin, even if they are nil per oral. Patients with TPN, the entire this thing is different, but that comes under critical the thing which I will not be talking about. Insulin requirement during a continuous 5D, again is going to be continuous. So you know the amount of glucose that's going inside. They are nil per oral with a very mild, let's say nausea, they don't want to eat. You put them on 5D. Then it is a continuous thing. There possibly an infusion would be the better thing. So thank you. What I was trying to convey is that in a patient who is not controlled, insulin would be the drug of choice. In a patient who is well controlled, who has come for a very mild illness, possibility of OHA use can be there. In a patient who's well controlled but is unable to palate, there are other procedures which is happening, then you would need an insulin this thing. Calculation is done best with an IV intravenous insulin this thing because of its plus point. Then calculate the dosage, split it and send them home. But make sure that you talk to them, make this as a learning experience, send them home with a prescription which will make sure that their control after the event is very good. Thank you.